bowel disease and the impact of new therapies targeting the JAK-STAT signaling pathway in IBD. So what I'm going to do today is I recognize that many in the audience are not gastroenterologists, and even those that are do not have extensive experience with inflammatory bowel disease. So the first thing I'm going to do is give a little bit of an overview of what IBD is and how it presents and commonly used mechanisms we use to score IBD in clinical trials. So that's going to be important when we talk about some of the clinical trials towards the latter part of the talk. And then I'm going to transition in a little bit to talking about JAK-STAT signaling and therapies that have been developed to target JAK-STAT signaling, and then the effectiveness of those therapies in inflammatory bowel disease. So first off, just in a way of overview of ulcerative colitis. So most of you likely know ulcerative colitis is a disease that affects the colon. It causes chronic inflammation in the colon. And we typically think of ulcerative colitis as a superficial inflammation and affecting the mucosa of the bowel. And ulcerative colitis, as many of you know, starts in the anus and extends proximally into the colon, where there's either an abrupt transition to normal appearing mucosa or the entire colon is involved by inflammation. And we classify ulcerative colitis based on the extent of disease. So if it involves the entire colon, or for that matter, any involvement that extends proximal to the splenic flexure, we determine pancolitis. If it involves, if it extends distal to the splenic flexure, we call it left-sided colitis. And if it only involves the rectum, we call it ulcerative proctitis. So the symptoms of ulcerative colitis include what you would expect: diarrhea, rectal bleeding, weight loss, abdominal cramping, and nighttime bowel movement. So anybody who presents with those symptoms, those can be alarm features and warrant a further evaluation. In addition, patients who have involvement of their rectum, so this is specific for proctitis. They have urgency to go to the bathroom, an inability to distinguish between gas and stool, and oftentimes if only the rectum is involved, patients will have urgency but will also have a sensation of constipation or bloating as well. So in our clinical trials of ulcerative colitis, the disease activity can range from quiescent disease, so ulcerative colitis is present although histologically inactive, to severe disease activity. And the most commonly used scoring system is termed the Mayo Score. And the only reason I bring this up is that I'm going to refer to it later in the talk. I don't bring it up for you to memorize here, but just understand that the Mayo Score includes an endoscopic subcomponent, which is probably the most important component, that ranges from 0 to 3, where 0 is healed mucosa, 3 is severe inflammation with ulcerations in the colon. And then there's 3 other subcomponents, including a rectal bleeding subcomponent, a stool frequency subcomponent, and then this generic physician global assessment. So when you add these up, each of these subcomponents ranges from 0 to 3, so the total score ranges from 0 to 12. The scores to remember here is that for most clinical trials in ulcerative colitis, at least with biologic agents and these Jak inhibitors, patients need moderate to severe inflammation, so they need a score of over 6 to be included in the trial. And oftentimes, especially in the newer or more recent trials, they need to have endoscopic inflammation as an entry criteria for the trial, so they need to have a Mayo endoscopy score of 2 to enter into the trial. And then healing is based on a Mayo endoscopy score of 0 or 1, and typically a total Mayo score of under 2 signifies clinical remission in many trials. So Crohn's disease, in contrast to ulcerative colitis, can involve anywhere in the gut. The most common site of involvement is the terminal ileum and or proximal colon. About 20% of patients with Crohn's disease have involvement of their colon alone. These are patients who can be difficult to distinguish whether they have Crohn's disease or ulcerative colitis. So you may have patients who said they have both, or said they were told they had ulcerative colitis at one point in time and then have Crohn's disease now, or vice versa. These are typically patients with Crohn's colitis. It's very unusual to have Crohn's disease of only in the upper GI tract or mid-small bowel involvement. So if you don't identify Crohn's disease by a colonoscopy or upper endoscopy, it's very unlikely that they have Crohn's disease. So in contrast to ulcerative colitis, which we think of as a superficial inflammation in the colon, Crohn's disease can involve transmural inflammation, and over time Crohn's disease progresses from an inflammatory phenotype, so primarily inflammation in the bowel wall, to fibrous stenosis or scar tissue leading to stricturing disease, to penetrating disease. And when we refer to penetrating disease, we're referring to inflammation extending through the bowel wall, leading to either fistulizing disease, so communication between two loops of bowel, or the bowel and bladder, or bowel and vagina, or bowel and skin, or an intra-abdominal abscess. So one of the goals of therapy, and this has emerged over the last 10 to 15 years, is that we want to treat Crohn's disease early, as we know patients with Crohn's disease will respond better to treatment earlier in their disease course when they're in this inflammatory phenotype, or if they've had surgery early after surgery before inflammation has set in, they're more likely to respond to therapies. So this is just some few examples and pictures of inflammatory Crohn's disease. You may not be able to see it from the back of the room. This does not work well, but you may not be able to see it from the back of the room, but you can see here these are pictures of inflamed mucosa with ulcerations in the ileum. And this is looking at fibrous and notic strictures in Crohn's disease. So on the upper left here, we're looking at a barium, a small bowel follow-through, which is a barium study, which we don't use as commonly anymore as in the past. But this nicely shows this transition from the small bowel to the colon. There's this long segment narrowing or stricture in the terminal ileum, and then the endoscopic appearance of the stricture with ulcerations is shown below. And on cross-sectional imaging, you can see pre-stenotic dilation of the small bowel. And penetrating disease obviously involves inflammation extending through the bowel wall, and this is where a patient, as shown on the CT scan here, has developed an intra-abdominal abscess that requires drainage and ultimately surgery. So as the clinical presentation in Crohn's disease is more heterogeneous than ulcerative colitis, our scoring systems in Crohn's disease are a little bit more complicated and involve more features than what's seen with ulcerative colitis. The most commonly used score that is going to be involved in the clinical trials that I present today is something called the Crohn's Disease Activity Index. And this includes multiple clinical points, including a patient's weight and hemoglobin, and each of these is weighted, so you get a total score, which can range up from 0 up to over 450. And the key numbers here to note is that most trials for entry criteria use a score of 220 to 450, so moderate to severe inflammation, and remission is commonly defined as a score of less than 150. Similarly, endoscopic scoring in Crohn's disease needs to take into account each bowel segment, as Crohn's disease activity can be patchy, meaning you can have an area of inflammation next to an area of no inflammation next to an area of inflammation. So the most commonly used scoring system is something called the simple endoscopic score in Crohn's disease, and this takes into account whether a patient has ulcers, the size of the ulcers, the extent of inflammation in each segment, as well as the presence of strictures in each segment. And so you total up the number of scores based on each bowel segment. So the ileum, ascending colon, transverse colon, left colon, and rectum together. When we look at healing in Crohn's disease studies, oftentimes endoscopic response will be defined as a 50% decrease in the score, and healing, which is pretty stringent, will be defined as a score of less than 2 overall. So to kind of transition into why this JAK signaling pathway is important in IBD, I'm going to present a case of why we need new therapies. And this will also illustrate the management of patients with active inflammation who you suspect need a change in therapy, as well as kind of touch on some of our currently available FDA-approved therapies. So just to start with the case, this is a 36-year-old woman with a diagnosis of Crohn's colitis that was based on colonoscopy. So she had a CDAI score of 300. So this is moderate inflammation based on clinical symptoms alone. And she was started on infliximab. As most of you know, infliximab is a monoclonal antibody against tumor necrosis factor alpha that was FDA approved for Crohn's disease 20 years ago. So it's been on the market for a while. And she was started at standard dosing. And she didn't have any improvement in clinical symptoms. Now, when a patient with IBD does not have improvement in clinical symptoms, we want to do a couple things. First is we want to make sure they don't have an infection. And one infection we worry about is C. diff infection. So we test this patient for C. diff and it's negative. The other thing before we switch therapies we want to do is confirm that they have active inflammation. And I'm going to show you why this is the case on a subsequent slide, is that especially in Crohn's disease, there's a disconnect between patients who have clinical symptoms and the degree of inflammation in their bowel, where some patients will actually be healed but still have clinical symptoms, and some patients will vice versa, have no clinical symptoms but have ongoing inflammation. They're at risk for future disease flares and complications related to their disease. And so this woman has a colonoscopy and there is active inflammation. C. diff and CMV are normal. And the other thing we want to do, especially with the anti-TNF inhibitors, is make sure their drug levels are in a therapeutic range before switching therapy. We want to make sure that the dose of that drug is optimized. And this patient had a trough level of 12 micrograms per milliliter, which is in a good range, and it's unlikely she would benefit from dose escalation of therapy at this point in time. So when patients are in a good range, they're not responding to therapy, we want to switch mechanisms of the drug. Switching to a drug in the same class as switching to adalimumab or certolizumab pegol would not be an effective strategy for this patient. And so she switched to vedolizumab. And vedolizumab is a monoclonal antibody against alpha-4 beta-7 integrin. Alpha-4 beta-7 is a protein that's on the surface of inflammatory cells, and it binds to MAdCAM-1. MAdCAM-1 is located on endothelial cells in the gut. And so what this drug does is it inhibits inflammatory cells from trafficking to the gut through this interaction between alpha-4 beta-7 and MAdCAM-1. This was FDA approved in 2014 as effective therapy for both Crohn's disease and ulcerative colitis, and very safe overall. However, she does not respond clinically, continues to have active inflammation, then switches to a third biologic agent, ustekinumab, which as you may know was initially FDA approved several years ago for treatment of psoriasis. And the doses used for psoriasis are either 45 or 90 milligrams every 12 weeks. This was FDA approved for Crohn's disease 2 years ago at higher doses, so it's given as an IV induction dose that's weight-based, and then 90 milligrams every 8 weeks. Again, she didn't respond. She went through this algorithm where she had a scope and infections were ruled out. So this really underscores why we need new therapies targeting new mechanisms, because each of these therapies alone, although in clinical trials much more effective than placebo, results in response rates in roughly half the patient, with remission rates and rates of mucosal healing significantly less than that. So this is just just to show you the endoscopy on this woman before we switch therapies. On the left here, I have a picture of a normal colonoscopy. So just to show the difference here. So you can see here that right here we're looking at the ileocecal valve and the cecum, and you can see, I don't want to make anybody dizzy or sick while they're eating lunch here, but you can see the nice glistening mucosa with normal vascular pattern coursing through the mucosa here. So this is a normal colon, okay? And let's just contrast that to this patient's colon. So you can see here there's no normal vascular pattern. You can see the ulcerations seen in erythema, and then when we do the power wash, you can see oozing of the mucosa. This is showing friability in the mucosal lining here. Here I'm going to take a biopsy just to show you the friability of the mucosa. You can see there's a fair amount of blood when we take a biopsy, showing inflamed, angry mucosa with ulcerations here. You can see these extended ulcerations through the bowel wall here. So anytime for all our therapies in IBD, there's two distinctions to keep track of. One is induction of remission, so we want therapies to get people well or induce remission, and the second is maintenance of remission, or therapies to keep people well. In general, most of our therapies are used for both induction and maintenance, with a couple exceptions. One is corticosteroids, which are good induction agents, but not good at maintenance therapy, given their long-term side effect. In contrast, immunomodulator agents such as 6-mercaptopurine and azathioprine are good maintenance therapy, but don't work well as induction agents. So why do we treat? So one is just for symptom improvement. The other is to improve nutritional status, primarily in patients with Crohn's disease. And then we want to minimize risk of both short-term complications, including corticosteroid use, extraintestinal manifestations. Patients with ongoing inflammation are at risk for blood clots as well. And then we want to minimize flares of disease and the significant morbidity associated with flares of disease, missed work, missed school, poor quality of life. And then long-term, we want to minimize the risk that these patients are going to need surgery. Patients with long-standing colitis, whether it's ulcerative colitis or Crohn's colitis, have a higher risk of developing colon cancer as well. Patients with Crohn's disease, if they progress to this fibrous Notic stage, can develop bowel obstructions and need surgery as well. And then for patients who have had multiple surgeries, they're higher risk for developing short bowel syndrome and may need to go on parenteral nutrition to maintain their nutritional status. So by treating, we try and avoid these complications long-term in these patients. So a key point here is that when the goals of our treatment are, one is to get a clinical response and remission, but really in 2018 we're shooting for beyond that. We want to shoot for endoscopic healing, and the reason why is that about 25% of patients with ulcerative colitis, this is showing a study in patients with ulcerative colitis, will have clinical symptom improvement but still have endoscopic inflammation. And we know those patients who are in that category, who have clinical improvement but endoscopic inflammation, are still at risk for complications over the next several months, including flares of disease and needing surgery. This is even more so in patients with Crohn's disease, where there's this disconnect between clinical symptoms and endoscopic activity. This is a classic study looking on the y-axis at the CDAI, or the clinical disease activity score, on the x-axis looking at the endoscopic disease activity. You can see this very poor correlation between the two. And we know that patients who heal early, whether they have Crohn's disease or ulcerative colitis, do better if we can achieve healing of the mucosa and not just improvement in clinical symptoms. So in 2018, mucosal healing is the goal of therapy and should be adjusted, and therapy should be adjusted, or changes in therapy, optimizing the dose when possible. I use that kind of in quotes, when possible, because we don't have, as I showed before, some patients just don't respond to many of our therapies, and we have to shoot for the best goals we can in these patients. So when possible, we want to achieve mucosal healing. So these are a list of our currently available FDA treatments. I went through many of these when I was going through the case here. So we have our conventional approaches. So aminosalicylate. So these are like the most commonly prescribed medications for ulcerative colitis and Crohn's disease. These are effective. So these are typically mesalamine compounds. These are effective in treatment for mild to moderate ulcerative colitis, and in some cases of Crohn's colitis. They are not effective therapies for Crohn's disease of the ileum. And then immunosuppressants and corticosteroids, which I touched on. The TNF-alpha inhibitors, of which there's 3 that are FDA approved for Crohn's disease: adalimumab, infliximab, and certolizumab pegol, and 3 that are approved for ulcerative colitis: adalimumab, infliximab, and golimumab. And then, as I mentioned, the ustekinumab, which is an IL-12 and 23 inhibitor, and vedolizumab, which is an alpha-4 beta-7 integrin. There's another alpha integrin, or an anti-integrin inhibitor, which is specific for alpha-4 integrin, that's FDA approved for Crohn's disease, and also used for multiple sclerosis, called natalizumab. That is very rarely used in Crohn's disease, given there's a risk, albeit low, of progressive multifocal leukoencephalopathy. And since vedolizumab has come on the market, we rarely see natalizumab prescribed in patients with Crohn's disease. And then tofacitinib, which I'm going to talk about subsequently, was most recently FDA approved. This is an oral small molecule inhibitor of Janus kinase that is FDA approved for treating ulcerative colitis. So a couple key points here. So about 30% of patients do not achieve an adequate response to their initial therapy, and that number is being generous. When you look at rates of remission in these patients, about 70% of patients do not achieve remission, either endoscopic or clinical remission on these therapies. And then patients who do respond, there's this risk of loss of response over time for once they're in remission on these therapies as well. So we can really improve upon our goals of both achieving remission and maintaining remission by having novel therapies that target new mechanisms and more effective therapies in patients with IBD. So, which brings us to why target the JAK-STAT signaling pathway. So, this slide really goes over the immunopathogenesis for inflammatory bowel disease, which, if I could summarize within 30 seconds on a single slide, I should be given an award, as people have spent their lifetimes doing research into this. And what we know is that IBD immunopathogenesis is complex and heterogeneous, and similar to the clinical presentation of inflammatory bowel disease and the genetics of inflammatory bowel disease, where there's over 200 genes that are involved in IBD, it's likely that there's numerous different inflammatory bowel diseases that we subclassify in this binary fashion of Crohn's disease or ulcerative colitis, and this affects this is reflected in the complexity of different pathways that are involved in patients developing IBD. In general, there's been three main themes that have come out of the research that have looked at the pathogenesis of IBD. One is disruption of epithelial barrier function. The second is an overactive pro-inflammatory immune response, and the third is inhibition of a regulatory immune response. So to date, most of our therapies, including the Jak inhibitors, have focused on this overactive pro-inflammatory immune response, targeting cytokines that are involved in pro-inflammatory signaling. So what are JAKs? I'm going to use that term generically. JAKs refers to Janus kinases, and of which there's 4. They're aptly named JAK1, 2, 3, and tyrosine kinase 2. And there's many different cytokines bind to their receptors in the extracellular domain of the receptor. And when these cytokines bind to their respective receptors, this results in activation of JAK proteins that then get phosphorylated on a tyrosine residue, and it results in recruitment of STAT proteins, of which there's 7. And these STAT proteins get phosphorylated as well. They dimerize and then go to the nucleus, where they affect transcription of pro or anti-inflammatory genes. So these JAK proteins can affect signaling of multiple cytokines. So which cytokines are these? And many of you have heard of many of these cytokines. These include IL-12 and 23, which are cytokines that are blocked by ustekinumab, IL-21, IL-13, which there's been a lot of interest in IBD, IL-6, of which there's inhibitors in rheumatoid arthritis that are FDA available, amongst others. And through inhibition of the JAK proteins, this affects signaling of these cytokines. So by blocking a single protein, you're able to affect signaling of multiple pro-inflammatory cytokines. And just to underscore this, the signaling pathways involved in multiple inflammatory pathways, including Th17 signaling, B cell switching, T cell homeostasis, amongst others. So, just to reiterate, a large subset of cytokines share this mechanism of single transduction, and JAK inhibitors directly inhibit activation of JAK signaling, and that downregulates an IBD immune inflammatory reaction. So how do these differ from the biologics I talked about before? And this is a key point. So first off, in contrast to the biologics, these drugs work intracellularly. Secondly, these are synthetic drugs, so small molecules and not proteins. And because they're small molecules, they can cross the epithelial barrier, and they can be taken as oral therapies, in contrast to our biologic agents, which are large proteins that cannot cross the epithelial barrier and need to be given as an infusion or an injection. In addition, because they're not proteins, patients do not develop immunogenicity against these drugs. So as you know, with drugs like infliximab or adalimumab, patients can develop anti-drug antibodies, and they can lose response or fight off the drug, or to have reactions to those drugs because they have anti-drug antibodies. This is not the case with these JAK inhibitors. So this becomes a little bit more alphabet soup when I go through these names, but I'm going to really focus on 3 inhibitors here. So, and most of my times when we talked about tofacitinib, which was the first JAK inhibitor that was FDA approved for ulcerative colitis. So there's 5 JAK inhibitors that are currently either FDA approved or in development for treating immune-mediated diseases, so including rheumatoid arthritis, psoriatic arthritis, and ulcerative colitis. So tofacitinib is an inhibitor of JAK1 and JAK3. Baricitinib is an inhibitor of JAK1 and 2, and this is FDA approved for rheumatoid arthritis. Has not been studied as, in IBD. Filgotinib and upadacitinib are JAK1 selective inhibitors that I'm going to go over some of the data in Crohn's disease subsequently. These are currently being studied in Crohn's, ulcerative colitis, as well as rheumatoid arthritis and psoriatic arthritis. And then the last drug is pefacitinib, which is a non-selective JAK inhibitor that a phase 2 study of ulcerative colitis was recently completed that I'm going to show and published. I'm going to show data of, and it's also being studied in rheumatoid arthritis. So another key point about these drugs, in contrast to the biologic agents such as anti-TNF alpha inhibitors that all work with a similar mechanism, although all these drugs are JAK inhibitors, they have different affinity for different JAKs, so they block different pro-inflammatory cytokines and may have differences in effectiveness, although we don't know that yet, and safety profile overall. So first off is tofacitinib. So tofacitinib has been studied. It was previously FDA approved for rheumatoid arthritis at a dose of 5 milligrams BID. Tofacitinib was studied in a phase 2 study that's not shown here in ulcerative colitis. That was a dose-ranging study, so they looked at doses of 5, 10, and 15 milligrams compared to placebo. And there was this nice dose response with the drug, which we like to see in our phase 2 studies, up to 15 milligrams twice daily. There were more side effects at that higher dose, so the company elected to pursue a 10 milligram twice daily dose as induction therapy for the phase 3 studies, as well as for maintenance of remission, either 5 milligrams twice daily or 10 milligrams twice daily. So what we're looking at in this slide is the phase 3 studies in ulcerative colitis called the Octave Trials. And these are 2 parallel phase 3 induction studies looking at remission rates at week 8. And these are pretty stringent criteria for remission rates. So this is a total Mayo Score, if we go back to the beginning of the talk when I talked about the Mayo Score, of less than 2, without any subscore of greater than 1, and having a rectal bleeding subscore of 0, so no rectal bleeding whatsoever on this drug after 8 weeks of therapy. And you can see here that the patients on tofacitinib did markedly better than those with a placebo. And given the stringent outcomes in the study, the placebo response rate was very low in this trial. You might say that 18% of patients in remission, that's very low, but that's fairly consistent with our previous studies in ulcerative colitis for remission rates. And when you take into account stringent outcome criteria and they get a low placebo response rate, it's a very good remission rate overall in this study, but also underscores the fact that we need to do better with our therapies in inducing remission in a higher percentage of patients. And then when you look at the remission data, so this is taking patients who responded, not remitters, but responded to the initial drug and then re-randomizing them to placebo 5 milligrams twice daily or 10 milligrams twice daily. The patients who received tofacitinib were able to maintain remission at about a 2/3 clip over the course of a year a 1/3 clip over the course of the study. A couple points here. The mucosal healing rate, which isn't shown here, was seen in about a third of patients at 8 weeks. So fairly robust mucosal healing data. And also patients who previously took anti-TNF inhibitors did well on this therapy. They did not do as well as those that were anti-TNF naive, although they did have a greater response rate than those taking placebo, which is not the case for some of our other biologics. And patients who took an anti-TNF before, they're less likely to respond to other biologic therapy. This drug was also studied in Crohn's disease as well. And this data here is looking at a phase 2 study in Crohn's disease. And what you can see here when you look at the primary endpoint in the study, which was clinical remission, there was no difference between the groups. I want you to just point out, though, this study had a very high placebo response rate in the study. So a third of patients on placebo responded to the drug. And this is one of the challenges when you only look at clinical remission as an outcome and don't look at endoscopic healing as an outcome. And when you look at the response rates, over half of patients receiving placebo responded to this drug. When they did subset analysis looking at biologic response, so when they looked at either the CRP during induction or the fecal calprotectin during a maintenance period, the patients who received tofacitinib had greater drops in both CRP and calprotectin. And then when they did a subset analysis looking at patients who had higher CRP, calprotectin, or higher endoscopic scores at baseline, so more severe activity at baselines, those patients did respond to the therapy. So there is a signal that this drug also works in Crohn's disease. However, because other drugs are being developed in Crohn's disease, the company that makes tofacitinib has elected not to pursue this further in clinical studies for Crohn's disease. So what about treatment of Jak inhibitors in Crohn's disease? So filgotinib is an oral JAK1 selective inhibitor. This is 50 times more selective for JAK1 than JAK3. So this is contrast with tofacitinib, which binds to both JAK1 and JAK3. And this was studied in a phase 2 trial looking at 10 weeks of therapy with 200 milligrams of filgotinib or placebo. And you can see after 10 weeks of therapy, the much greater remission rates with filgotinib, and about close to 2/3 of patients in this trial did see a response who were receiving filgotinib. When they looked at mucosal healing after 10 weeks of therapy, they did not see significantly different mucosal healing rates with this drug, although keep in mind this was a phase 2 study, so not a large population of patients studied in this group. And with Crohn's disease, we think that it may take longer to achieve mucosal healing. So 10 weeks may be too short of a time period to achieve mucosal healing in studies with Crohn's disease. Getting to that point of anti-TNF experience versus anti-TNF naive patients, with filgotinib, patients who were anti-TNF naive did better than those who were anti-TNF experienced patients, which is similar to what we've seen in other biologic trials as well, although there were higher response and remission rates, in patients who were anti-TNF experienced, there was a higher response and remission rate in those who were on filgotinib than placebo. So there's several ongoing clinical trials looking at filgotinib, both in ulcerative colitis and Crohn's disease, including important groups of patients that we don't have great clinical trial data in, and these are small bowel Crohn's disease and perianal fistulizing Crohn's disease, where we do need more effective treatments. Similar to filgotinib, upadacitinib is an oral JAK1 selective inhibitor that is even more selective for JAK1 than filgotinib is, so it's about 75 times more selective for JAK1 than JAK3. And this was studied in a phase 2 study. And the difference between this study and the study I just presented is this was a dose ranging study. So they took patients and gave them different doses of the drug compared to placebo. So keep in mind there's smaller numbers of patients receiving each individual dose of the therapy. And they used a little bit of an unusual scoring system for entry criteria and response, where it was based on the number of liquid bowel movements per day and whether they had abdominal pain. You can see overall at this dose of 6 milligrams twice daily, there was a trend towards a difference, although keep in mind it's a small sample size. And then when you took patients at the highest dose of the drug and they looked at mucosal healing at 16 weeks of therapy, more patients on upadacitinib achieved mucosal healing compared to those on placebo. So this drug does look promising from a standpoint of patients with Crohn's disease. And this data is looking at the dose response. And this is what you'd like to see in phase 2 study. You'd like to see this kind of incremental improvement in symptom control with higher doses of the drug, up to 24 milligrams twice daily. And keep in mind, the patients did see an early response. So as early as 4 weeks of therapy, patients did see a response to therapy. And so this drug as well has moved on to other studies in Crohn's disease and in ulcerative colitis. And it will be of interest to the field to look at the response rates in these phase 3 studies with JAK1 selective inhibitors. Lastly, I just wanted to mention briefly this study that just came out looking at pefocitinib. So pefocitinib, in contrast to the other drugs that I mentioned, is a non-selective JAK inhibitor that's being studied in rheumatoid arthritis as well as ulcerative colitis. And when you look at the studies in ulcerative colitis, in contrast to the other phase 2 studies or the last phase 2 study I showed where you saw this nice dose response, you don't see that with pefocitinib, although patients who had received a dose of 75 milligrams daily and higher with this drug did see a response. So there was a dose over that threshold, but you don't, when you went to doses higher, so 150 milligrams daily or 75 milligrams twice daily, you did not see this incremental dose effect in ulcerative colitis at 8 weeks of treatment. The primary endpoint was at 8 weeks of treatment, and when they did the combined doses, more patients did respond, looking at the partial Mayo Score. So partial Mayo Score is the Mayo Score I presented earlier, but doesn't include endoscopic criteria, but they also had a response when they looked at mucosal healing. So this drug does look like it has some promise in patients with ulcerative colitis as well. When they looked at, I'm going to go over the safety of the other drugs subsequently. The one safety feature that was shown with this study that was not seen with the other drugs is that about 4% of patients in this study did have increases in their creatinine kinase on blood draw on this therapy. So, which brings me to the next question is how safe are these therapies? So this is data looking at tofacitinib, so looking at 1 year of therapy with tofacitinib from the phase 3 studies with tofacitinib. And you can see that overall the rate of adverse events and serious adverse events was similar in patients who received placebo versus those that received the 2 doses of tofacitinib. When you looked overall at infection rates, though, those were higher on tofacitinib than placebo. And the one infection that stands out, which is known with this drug, is herpes zoster or shingles with this therapy. So about 5% of patients who received the higher dose of tofacitinib developed shingles during the 1 year of follow-up. When you look at data from the rheumatology literature, looking across all clinical trials and follow-up, so we're talking over 6,000 patients with close to 20,000 patient years of exposure, the rate of herpes zoster is about 4% on the higher dose of therapy. The rate of malignancy overall is low. Keep in mind there's no control group to which this compares. The one other safety signal that's of concern is there's a small percentage, so about 1 in 1,000 of GI perforations on this drug, which interestingly in the trials with ulcerative colitis has not been seen, aside for I think a single patient in these trials. And whether that's, you would think that patients who have ongoing severe inflammation in their colon will be higher risk. We don't know why that is. It may be the fact that the perforations in rheumatoid arthritis may be taken in patients taking NSAIDs, which we know increase the risk of perforations, or something inherent with rheumatoid arthritis. So it'll be interesting to get some post-marketing data with tofacitinib to see if this risk of GI perforations is increased in patients on tofacitinib, especially when you compare it to placebo or control patients who with ulcerative colitis and Crohn's disease. Filgotinib, because it's a JAK1 selective inhibitor, there's been an interest in looking to see if the rate of adverse events is lower than with less selective JAK inhibitors. Keep in mind this was a 10-week study with 10 weeks of follow-up in a maintenance phase, so 20 weeks, so relatively limited follow-up. Overall, the safety profile looked excellent. There was not a significant increased risk of adverse events or infections in the patients treated with filgotinib, and the rate of herpes zoster in the study was low. So what about this rate of herpes zoster? Interestingly, there are regional differences, so it tends to be highest in Asia on this therapy, and it's about a 1.5 to 2-fold risk compared to patients taking other therapies. Fortunately, as many of you know, there's a new inactivated vaccine that was recently FDA approved, the Shingrix vaccine that's FDA approved for all patients over age 50. That I've been giving this to all patients regardless of their age when they're started on tofacitinib to try and prevent herpes zoster in this patient population. The older generation of shingles vaccine is not recommended for patients on this therapy. One, it's less effective, but two, it's a live vaccine, so it's not recommended for patients on immunosuppression. So from a patient perspective, in patients we've started on this therapy, their major concerns when talking to them in the clinic are, one, about the mode of delivery. They're overall, there tends to be a fair amount of excitement about this therapy, especially for patients who had previously had to go in for infusions at a regular basis, or who were giving themselves injections at home. So to have an oral therapy, there's always concerns about safety, and any patient is always concerned with a new therapy about unknown safety effects of new therapy that to this point in time, when talking to patients, I recommend going over the clinical trial data, but also the data that's available in rheumatoid arthritis, and discuss those therapies with the patient. And then finally, as with the case with any of our therapies, is getting patients' insurances to approve of these therapies. I have not had difficulty with getting approval for tofacitinib. I've not given it as a first-line agent to patients, though. All the patients I've started on have failed at least one biologic therapy in the past. So in conclusion, the JAK-STAT pathway is a rational target to decrease inflammation in patients with IBD. These JAK inhibitors are effective at inducing clinical remission in both ulcerative colitis and, at least in clinical trials, in Crohn's disease, although not FDA approved at this point in time for patients with Crohn's disease. The overall safety profile in patients with IBD seems to be very good and without significantly higher risk than our other currently available FDA treatments, or for that matter, corticosteroids, which are typically an alternative in these patients. And these therapies are kind of going to usher in a new wave of oral small molecule inhibitors that are being developed for IBD and other immune-mediated diseases that are currently in trials. So there's going to be a slew of new oral therapies that become available over the next decade or so. We still don't know several questions with these therapies. So one is how to position this therapy against our other therapies. And this is something that always comes up in clinic. And actually, I was just talking to the mom of one of my patients before this talk about what therapy to start on a patient. It's almost like throwing darts at a dartboard in terms of deciding what therapy to start on an individual patient. As we don't have predictors of who's likely to respond to a given therapy, other than the patient preference of route of delivery, the insurance approval of these drugs, and in some cases the safety profile. So, for instance, in patients who are older, vedolizumab may be a more effective, safer therapy in patients. The one case that we can make for tofacitinib, although we don't have evidence to support this, is that given that the other therapies are all protein-based therapies, we know that patients with low albumins who are sicker are less likely to respond to those therapies. We think that's because they lose the drug through just like they're losing protein through ulcerations in their bowel, they're losing the drug through their bowel. So potentially an oral therapy that's not protein-based will be a more effective strategy. We have seen that with other therapies such as cyclosporin and tacrolimus. Whether that's the case with tofacitinib, we do not know. We also don't know whether combination regimens, such as combining this with oral or injectable methotrexate or 6-mercaptopurine or azathioprine, is an effective or even safe strategy in these patients. So these are areas of interest that are going to be studied in the coming years, and hopefully we'll have better answers to those questions. So that, I know I went through a lot, and a little bit of that is like alphabet soup, going through some of the names of these drugs and their effectiveness. But hopefully I gave you a little bit an overview of IBD, the rationale for targeting this pathway and the effectiveness of these therapies, and knowing that these are going to be used more frequently in the future. So when you see patients in clinic on these therapies, you'll have an understanding of how to adjust the dose and respond to potentially the complications of these treatments. And I'm happy to take any questions. Yes?
Are all these drugs available clinically?
So the only drug that's available for ulcerative colitis right now clinically is tofacitinib, is a brand name of Xalgens. That's also FDA approved for rheumatoid arthritis. Baricitinib was also recently FDA approved for rheumatoid arthritis. I don't know if it is available in the clinic as of yet, but should be soon if it's not. The others are all in phase 3 studies, so kind of they're kind of being pushed closer to FDA approval, but not there yet.
Cost factor?
So these drugs are, I off the top of my head, don't know the cost if you were going to pay for these out of pocket. These drugs are expensive. From what I know, there's not a major cost difference for the biologic therapy. So we're talking thousands and thousands of dollars a year for these therapies. So typically we only start these when the payers are willing to cover the cost of these drugs. Before FDA approval of these therapies, we at least at the University of Chicago, we were able to get many patients tofacitinib with for compassionate use from the manufacturer and covered by the manufacturer of the drug. I don't know if that's still the case now that it's been FDA approved, but it has not been an issue. But I'm also a little bit biased because we have a very good specialty pharmacy that does all the work for me. So they've been successful in getting patients coverage for these therapies. Other questions? Well, thank you very much for having me here today. It was a pleasure, and thank you for the nice food.